Okay, John Kanellopoulos here from our center in Athens, Greece, the LaserVision ambulatory surgery unit and clinical professor of ophthalmology at NYU Medical School in New York City, New York. Our favorite subject, we'll talk about keratoconus. The difference here is that we have a 50-year-old gentleman. As we can see, the eyes are good. The lens shows that we're over 40, left eye as well. And bingo, although this gentleman for 50 years is wearing 4.5 diopters of astigmatism on his right eye with 3 diopters of myopia, only 0.75 diopters of astigmatism in his left eye with 4 diopters of myopia. He recently discovered he has keratoconus. Why is that? Let's first answer that question. The reason being is that many people call this pellucid marginal, which is not, because there's a claw-like view of the cone. The reason being is that it's an oblique cone. We'll see that later and establish that. And centrally, for this patient, the astigmatism is relatively regular. His IHD is just 0.078, although he's keratoconus stage 2, and his ISV is 61. And the other eye, the same values are IHD 0.012, it's normal up to 0.016. So there's something tricky with the IHD. ISV is normal as well. And we've talked a lot, published on how the anterior surface symmetry indices are very important in picking up keratoconus, especially if it's not central. The other reason that he's so well and he's seeing well all these years is that he has a very small pupil. So don't underestimate that. Small pupil and a keratoconic eye means it forgives a lot. So what's important to this 50-year-old is to establish whether keratoconus is active. And you guessed it, the next thing we want to see is his epithelial maps. And these are the epithelial maps of the right eye that has the more advanced keratoconus. And the epithelium at that thin area of the right eye, which is somewhere in this ballpark, is absolutely naive. So no epithelial changes. There's no blue on the Vanti OptiView map showing thinning and thickening around it. The total corneal thickness is very good, 566. We'll throw this away. We'll go and look at the 4 maps refractive of this keratoconic eye. And we can see here where the posterior corneal curvature definitely flags the concavity if you flip the cornea upside down where the cone exists. Also, the apex of this cornea is not centrally, is infero and slight infero-temporally, if you may. So this is indeed oblique keratoconus. It's not pellucid because the peripheral cornea is thicker than the thinned area. It's an oblique cone. It acts as regular astigmatism centrally. We can also see the pupil here on the pentacam. And looking at the other eye, whether the other eye is normal, the only thing that flags, and we've talked about this, that this is an abnormal eye, is not the anterior elevation, which is central. The posterior elevation, one may say it's central. The thickness maps have this infero-temporal skewing that's not regular. So although the topography maps are normal, this for us flags a keratoconic predisposition. He does not sleep face down. His epithelial maps kind of establish that. And he has a 10-year-old son with 2 diopters of myopia. So guess what? That's the patient that we want to see and evaluate closely through puberty. Because if he has dad's predisposition to keratoconus, we want to make sure he's not an eye rubber. And how we're going to establish that? With the epithelial maps. And now we know more about keratoconus than most clinicians worldwide. And again, small pupil, relatively regular astigmatism centrally is the key thing here. This is John Kanellopoulos on my favorite subject, keratoconus. I hope you found this interesting. Signing out. Thanks so much for your attention.